Alright, here we are on the last chapter of the book. Amazing. Probably thought we'd never get here. But chapter 19 we're going to talk about support systems, which is the blood supply to the brain and the cerebrospinal fluid system. There is a lot of information in the book about specific arteries and what they affect and what areas they supply and that sort of thing. And I really do not... you don't need to know all of that. I do want you to know about certain ones, and I'll tell you which ones. But we're going to start talking about the cerebrospinal fluid system. So the cerebrospinal fluid, or CSF, which we will call it from now on, it's a system that regulates the extracellular milieu, as they like to say, or the extracellular environment of the brain, and it protects the central nervous system. It provides a little bit of cushioning effect and nutritional effect. So it's formed primarily in the ventricles, which are little openings in the brain and central nervous system. It circulates through the ventricles and into the subarachnoid space before being absorbed back into the venous circulation. So it has a one-way circulation, and we'll talk about that. The job of the CSF is it supplies water, certain amino acids, and specific ions to the extracellular fluid, and probably removes metabolites from the brain. They say probably because it's not exactly proven how it does this, but it performs nutritive functions, just like the other fluids in our body, but this one is specific for the central nervous system. So the ventricles are CSF-filled spaces inside the brain, and it forms a system of 4 ventricles. So there are some pictures. One of these is a cross-section of an actual brain. It's an anatomy picture, and the other one is a drawing of the ventricles, so you can kind of see how they're arranged. So the lateral ventricle, and you don't need to know all the specific names of the horns and everything of the ventricles, but there are 2 lateral ventricles, one in each cerebral hemisphere, and then they join together to form the 3rd ventricle. The cerebral aqueduct runs through the top of the brain stem to the 4th ventricle, and the fluid only flows one way. So there's this there's a picture. It's in the book, it's on page 463. It's figure 19-3, and I also have it in the module. Let's see. Oh, there it is. So the CSF circulation is unidirectional. So it's formed from the blood by filtration, active transport, and facilitated transport. It flows from the lateral ventricles into the 3rd ventricle via the interventricular foramina. Then it goes from the 3rd ventricle to the 4th ventricle via the cerebral aqueduct. It exits the 4th ventricle through the lateral and medial foramina, entering the subarachnoid space. And within the subarachnoid space, it flows around the spinal cord and brain, and that's where it provides that cushioning effect. And then it's finally absorbed through the arachnoid villi into the venous sinuses. Okay? So it's that unidirectional flow. It always goes in that direction. There are some disorders that are associated with CSF. So they're all listed on this lovely little chart. That's really all I want you to know, is that the CSF flow is unidirectional. I want you to be able to state what the functions of the cerebrospinal fluid is: providing water and amino acids to the extracellular fluid, supplying specific ions, and buoyancy to the brain for that cushioning effect. The disorders: epidural hematoma. So epidural. It's arterial bleeding between the skull and the dura mater. Most often results from a torn middle meningeal artery caused by fracture of the temporal or parietal bone. So it's usually a trauma thing. The signs and symptoms are headache that keeps getting worse, vomiting, decreased consciousness, sometimes hemiparesis and Babinski's sign if it progresses to that point. A subdural hematoma, it's venous bleeding. The symptoms are similar to epidural hematoma, but they tend to gradually worsen over days or months. So the epidural hematoma, the symptoms are pretty acute. The subdural hematoma often isn't detected because the symptoms gradually worsen over days or months. Hydrocephalus is where the CSF circulation is blocked and pressure builds up in the ventricles. So there's they talk about the congenital hydrocephalus, where someone is born with CSF circulation problems. And the signs and symptoms are a large head because there's the buildup of CSF, poor feeding, so they don't want to eat, inactivity, and a downward gaze. There's also something that happens in adults that's called normal pressure hydrocephalus, and sometimes it happens spontaneously. They don't know why. It could be a tumor, it could be some other issue that blocks CSF circulation, and a lot of times there are cognitive and balance effects from the hydrocephalus. So you don't get the large head and the downward gaze and that sort of thing, but you get more cognitive and balance effects. Meningitis, it's inflammation of the membranes surrounding the brain or spinal cord. It's often caused by a bacteria or virus. It causes headache, fever, confusion, and vomiting. And it's a serious medical thing that needs to be treated right away. There are some of the forms of viral or bacterial meningitis there are vaccines for, which is great. Untreated meningitis can progress into brain damage, so it's a big deal. It's definitely, all of these things are big deals. Anything affecting the brain, you know, it should be treated pretty quickly. So the meninges we talked about in the spinal chapter. They're the same 3 layers. The dura mater surrounds the brain and spinal cord, consists of the outer layer firmly bound to the inside of the skull and an inner layer. The arachnoid is the middle layer. It's a delicate membrane that's loosely attached to the dura mater. And the pia mater is tightly opposed to the surfaces of the brain and spinal cord. Okay, and so the subarachnoid space, you'll hear in some of the descriptions of pathologies, it's the space between the arachnoid and the pia mater. So if you get bleeding into that subarachnoid space, subarachnoid hemorrhage, it's going to put pressure on the brain. So this picture's in the module. It's from the book, and it just shows the arrangement of the meninges. Just a coronal section of the meninges. So we talked about cerebrospinal fluid flow and disorders of the cerebrospinal fluid. So when we start to talk about the vascular supply of the brain, it's obviously the vascular supply of the brain is really important. The cerebrum demands a lot of blood, and it cannot live without it. And so anytime you get disorder, you get interruption of the blood supply to the brain, it's a serious issue. So loss of blood supply in a specific area of the brain correlates with specific loss of function. Just like in the last chapter when we talked about the functions of individual areas, it makes sense, right? So if you lose blood supply in a specific area, you get a specific loss of function. So there are different patterns or progressions of vascular disruption in the brain. There's one type that's called a transient ischemic attack, or a TIA. It's a brief focal loss of brain function with a full recovery from neurologic deficits within 24 hours. So this, if you compare CVA to MI, or heart attack, myocardial infarction, this is sort of the angina of a stroke. So the artery's blocked for a little bit, and then the block frees itself, and they regain function. So a lot of times when you're in an acute care setting, you'll see someone admitted under the diagnosis of CVA versus TIA. They suspect it might be one of the two, and they're doing diagnostics and imaging, and they're observing the person to see if it's one or the other. A lot of times people have several TIAs right before they have the big stroke. So it's something you need to be hospitalized for. But they get the full recovery, and that's how they know the difference. And then also it doesn't show up on imaging usually. There's not a big clot that they can bust with the clot busting drugs. A lot of times it's a lot of tiny clots. Frequently it will be treated with anticoagulants because they're trying to decrease a chance of more clots building up. Of course, you don't want to go to the other side of being too anticoagulated, because then you can end up with a hemorrhagic stroke. Not good. So a completed stroke means it's not a TIA, you don't get full recovery. The neurologic deficits from vascular disorders persist more than a day, and they're stable, they're not getting worse. A progressive stroke, the deficits are increasing intermittently over time. So sometimes with a hemorrhagic stroke, you'll get that progressive stroke because you're bleeding out to more areas of the brain. Or remember in chapter 4 when we talked about excitotoxicity, you get an ischemic area, it releases all that glutamate and it kills other cells, and so you get some progression and the symptoms increase. So CVA, cerebrovascular accident, is synonymous with stroke. There are medical community is now trying to advocate brain attack as the layman's term to replace stroke, to emphasize that prompt treatment is important. So there's been a lot of public education, everything about heart attacks and what the symptoms are and how you have to get people right in and that sort of thing. Well, a stroke is a brain attack, and they want people to know that you should get people right in. Let's see, how long ago did I work in the emergency room? It was a long time ago when I was an EMT. It was in the early 80s. We didn't have the same treatments for strokes that we have now. And so when somebody came in on an ambulance with a stroke, there was not anything they could do for them except monitor their vital signs. And so people had a lot more lasting effects and a lot more progression of a CVA without the clot busting drugs and without some of the treatments they can do now. They're actually even going in surgically and removing a clot or putting a stent in. They're doing brain surgery as a treatment for stroke, and people get better return with that and less loss. And so just to educate the members of the community that a stroke is a brain attack, just like a heart attack, and people need to get in right away. So it's the acronym for the symptoms you're supposed to look for is FAST, and it's face, arms, smile, and time. So face has your face changed? Is one side different from the other? Arms, can you lift one arm more than the other? Smile, is your smile even, or is one side droopy? And speech, S can stand for smile or speech, if your speech is slurred or anything like that. And then timing. Timing is of the essence. You have to get people in. So that's the thing you ask someone. Can you speak? Can you smile? Can you lift your arms? Call 911 and get in there. So a brain infarction, also known as ischemic stroke, occurs when an embolus or thrombus lodges in a vessel obstructing the blood flow. Typically, the embolus abruptly deprives an area of blood, resulting in an almost immediate onset of deficits. So obstructions of blood in small, deep arteries result in lacunar infarcts. We'll talk more about this. and slow occlusion of an artery has a different outcome than abrupt occlusion. So if there's a clot that's stuck and it's just slowly closing off the artery, you'll have different outcome. So there's this pie chart, and the one big thing I want you to notice, this is in the module, this is in the book, this is in the PowerPoint, that big red area, 69% of ischemic stroke affects the middle cerebral artery. That's a huge number. So all these other arteries that are possibly affected to different levels, small percentages, a huge percentage of ischemic strokes affect the middle cerebral artery, and that produces the effects that we see, that we talk about when we talk about, you know, left CVA, right hemi, right CVA, left hemi, the standard effects. You can have strokes in that affect other parts of the brain, that affect other arteries, and you'll get different effects. I worked with a guy one time who his brainstem, the basal ganglia area was affected, and he had effects that looked a lot like Parkinson's. It wasn't Parkinson's, it was a stroke. But the most common kind of stroke is that middle cerebral artery stroke, and that's what you will see 69% of the time. So and that information is from 2011, so it's fairly recent. And so that's one of the things why those sort of stereotypical stroke symptoms, those are usually middle cerebral stroke symptoms. So there are a couple other different kinds of strokes. I have another chart that is what I want you to know, but if you want to go through the PowerPoint and look at these stroke symptoms by arterial location, it describes it. And then there's also some slides on arteriovenous malformations and aneurysms, and those type can cause hemorrhagic strokes. So you don't necessarily have to know all the details on those, but here are the charts that I want you to look at. The disorders of vascular supply, the disorder and its description. So a TIA, it's brief focal loss of brain function with full recovery within 24 hours. Risk of stroke is high following a TIA. A completed stroke is neurological deficits that persist more than a day and are stable, so they're not progressing or improving. Progressive stroke deficits are increasing intermittently over time. Just a stroke in general, CVA, brain attack, is a brain infarction that occurs when an embolus or thrombus lodges in a vessel obstructing blood flow. That's the ischemic CVA. An embolus is a clot, and it deprives an area of brain of blood, resulting in immediate onset of deficits. A thrombus, so thrombic ischemia may be abrupt or it may worsen over several days. Recovery is usually slow and significant, they say, meaning they recover very well from it, and a residual disability is common. So a recovery is slow and significant residual disability is common. That's what I'm trying to say. It's a slow recovery because with thrombic ischemia you usually have a lot of clots, so there are a lot of areas affected, and that's why it worsens over several days. The lacunar infarct is obstruction of blood flow in small, deep arteries. Signs develop slowly and are often purely motor or purely sensory. It has a good recovery. Hemorrhage deprives the downstream vessels of blood and exerts pressure on the surrounding brain tissue. Subarachnoid hemorrhage is bleeding into that subarachnoid space, and it usually causes sudden, excruciating headache with brief loss of consciousness, and the deficits are progressive. Okay, so stroke signs by arterial location. I'm going to start with the middle cerebral artery, since that's the most common. The signs are homonymous hemianopsia, contralateral hemiplegia, hemisensory loss involving the upper limb and face, and language impairment. That sounds familiar, doesn't it? That's sort of our standard stroke, if you want to say that. The anterior cerebral artery, it affects the frontal lobe. Frontal lobe is personality. So you get personality changes with an anterior cerebral artery. That makes sense, right? And you get hemisensory loss. It's in the front of the brain. The sensory areas of the cerebrum are more towards the front. The posterior cerebral artery, you get contralateral hemiparesis. More motor areas are affected. Eye movement paresis or paralysis because the brainstem can be affected. Cortical blindness because the occipital lobe can be affected. So it's posterior, it's the occiput. Memory loss because the memory areas are in the temporal lobe, and that's more posterior. And severe pain is often associated with posterior cerebral artery. When we talk about the vertebral or basilar arteries, it's going to affect more the cerebellum. So gait and limb ataxia. Remember ataxia being one of those cerebellar symptoms. Limb weakness, ocular motor palsies, because that is affecting the pons. And oropharyngeal dysfunction, again, it's basilar, it's affecting the brainstem and the cerebellum more than the cerebrum. Okay, so I just want you to kind of know the differences between those. There's that chart again. Oh my gosh, middle cerebral artery, that's most of them. Homonymous hemianopsia, contralateral hemiplegia, hemisensory loss involving the upper limb and face, and language impairment. Okay, so big red area, 69% of strokes, middle cerebral artery, also known as an MCA stroke. So cerebral edema is accumulation of excess fluid in the brain, frequently caused by concussion. It can also be caused by cardiac arrest and high altitude. You can get cerebral edema from going to extreme high altitudes. The signs and symptoms are headache, weakness, disorientation, memory loss, possibly hallucinations and psychotic behavior. It can induce coma. And less frequently, you can see ataxia. And that's because of pressure that gets on that posterior chamber and the cerebellum. Okay? So, really, the charts in this module are what I want you to know for the test. I made charts for you, just so you could know what to study. I'm also going to have a study guide, just like I have had for the other two exams. And I know that you guys will do fantastic on the exams, but I also want you to gain an appreciation for the information that we are learning, as well as doing well on the tests. Okay? So as usual, any questions? Post them. And we will have some chat reviews before the next exam. We'll have a week after this week for review. We'll have one review assignment, which will involve you writing exam questions. And I'm sure all of you have a good start on your winter quarter project, interviewing someone with a neurological disorder and doing some research on their disorder. And I can't wait to read them all. So we're wrapping it up. This is the last lecture for the quarter.